Postoperative pain assessment and management. The management of pain has often been assumed to be a routine part of care. However, pain is an under-identified problem postoperatively and continues to be vital as nearly all patients experience pain post-surgery. Postoperative pain can bring about complications such as increased stress, restricted mobility, prolonged recovery periods, readmission, and increased hospital stay. The reasons for why postoperative pain is still occurring are well researched and comprise of patient and professional barriers, lack of assessment, and organizational practices that restrict administration of analgesics. Even with knowledge of preemptive and multimodal analgesia, changes to practice are not advancing. Pain is subjective and reflects the person's disease, life experience, religion, and culture. The goal for analgesia is to provide patient comfort. It is patient-specific and depends on the clinical situation, individual patient tolerance, and side effects of analgesic therapy. Effective pain management increases patient satisfaction, improves patient outcome, and reduces the cost of care. Pain management in the acute postoperative period is complex due to the uncertain variability of pain, patient characteristics, and pharmacological factors. Good pain management includes frequent in-depth assessment of patient's pain as this provides knowledge to achieve pain control. The assessment should document pain severity, response to medication, and development of any side effects if necessary. The early post-anesthesia recovery period presents challenges for the nurse as the priorities for assessment and care of patient include the assurance of patient's physiological stability, which may delay pain assessment. They must also depend on their knowledge but the artful interpretation of the patient's response to assess pain effectively. Pain assessment must be modified to the communication capacity of the patient. Patients may be unconscious or unable to self-report, therefore behaviors need to be assessed to identify pain. Part of the surgical process is experiencing pain. However, it is vital that health professionals attempt to reduce postoperative pain because it poses clinical, psychological, and economic problems. If pain is managed inadequately, the resulting surgical stress response results in negative outcomes for the patient, such as deep vein thrombosis, pulmonary embolism secondary to pain-induced immobilization, extended length of stay, readmission, and patient dissatisfaction. A report from the United States National Institute of Nursing Research identified pain as a major factor contributing for prolonging length of stay and resulted in negative patient outcomes. Pain prevention strategies, early detection of physiological consequences of pain, and improved holistic pain management should be the main focus for nurses in the postoperative period to reduce postoperative pain complications associated with SSR. A qualitative study conducted by Van Dijk et al. In 2012 to 2013 explored how patients assign a number on the basis of the numeric rating scale to their currently experienced postoperative pain. This study found that patients translating experienced pain into an NRS score between 0 to 10 as a complex process, as they believed their pain was individual and could not be scored simply by one number. A single number associated with the NRS scale does not give the health professionals a holistic explanation about the experienced pain. Rather, health professionals should perform questionnaires to gain insight. To reduce anxiety related to pain, patients need to be reassured and justification given that they are in pain and will be given analgesics. Organizational factors can restrict the administration of analgesics, making postoperative pain worse for the patient. Factors such as staffing level, time of day, availability of health professionals, and workplace culture all affect the ability to make clear decisions about patients' postoperative pain management. A literature review of 5 articles from the years 1996 to 1999 reported on research of nurses' management of patients' postoperative pain. They found that nurses' attitudes, beliefs, experience, and culture were established as influences on the nurse's likelihood to perform pain assessment and management. To ensure that pain management is treated effectively, health professionals must ensure that pain management strategies are handed over. To optimize pain treatment, patients and health professionals must gain a therapeutic relationship that allows for therapeutic communication and the ability to work collaboratively with an understanding of the burden of pain. An ideal drug would incorporate the characteristics of rapid onset, rapid recovery, lack of drug accumulation, and no side effects. Despite this, there is no drug that has all these qualities. Therefore, a multimodal approach is employed. A multimodal approach is the combinations of analgesic and techniques. Each have a different channel of action with the peripheral or central nervous systems, different routes of administration, and non-pharmacologic interventions. A systematic review conducted by Brubaker et al. Aimed to characterize the role of local non-steroidal anti-inflammatory drugs in non-ophthalmologic postoperative pain. They reported that large randomized control trials are minimal. However, there is new evidence to support the beneficial local administration of NSAIDs as an adjunct to postoperative pain management as it can be beneficial in improved analgesia, reducing opioid doses, and decreasing the risk of opioid-related side effects. George W. Krill developed the belief of preemptive analgesia for postoperative pain control in 1912. He based his assumptions on clinical observations that suggested that analgesia was more effective when they were administered before a surgical procedure. Penrose et al. Conducted a systematic review of the literature to present current research regarding best practice related to preemptive analgesia. The results of the review showed that NSAIDs aren't suitable for preemptive analgesia, but found that postoperative administration provided pain relief and decreased the intensity of pain. Regardless of the surgical procedure, the literature showed that COX-2 inhibitors had a positive effect on postoperative pain scores, opioid use, and length of hospital stay. Administration of preoperative gabapentin displays effective results for controlling postoperative pain. The results from this systematic review displays the need for perioperative nurses to understand the use of preemptive analgesia so they can decrease postoperative pain. Many patients are still experiencing postoperative pain after several decades, indicating that there is need for improvement in pain management to reduce complications. Improvements such as providing reassurance and justification for the patients to reduce anxiety, improving health literacy, and ensuring that pain management strategies are communicated in handover. Optimal pain management involves the complex interaction of patient self-reports, behavioral and physical manifestations of pain, attitudes and beliefs about pain, knowledge of treatment, and previous experience with patients in pain.